Okay, so now we're going to talk about paralytic ileus, which is usually a post-op complication. So what happens when an abdominal surgery is done? We have immobility because of the surgery, sometimes because of the illness that made the surgery necessary. And then we have anesthetic, which slows the gut down. Then we have post-op pain meds that slow the gut down. Sometimes meds are given to relax the bowel in surgery to allow the surgeon to do their work. And we also have the surgeon handling the intestines, all of which can cause a portion of the intestine, usually the ileal portion of the small intestine, to actually become paralyzed. So this is a post-operative complication, and it's an intestinal obstruction, not an actual physical obstruction of the intestine, but the intestine doesn't move. That section of the intestine is paralyzed. So the things that contribute to it, besides we've talked about meds, we've talked about anesthesia, we've talked about manipulation, but also if the patient has an infection, in particular an infection in the bowel, and electrolyte imbalances can all contribute. So what happens when we are managing that? Usually we're going to need to decompress the stomach. So if the small intestine is paralyzed and isn't moving, I want you to think about what you would expect to see in your patient. You would expect your patient to feel nauseated, their stomach is filling up with acid bile, and if they've had anything in, any liquids or hopefully not foods, but if they've had anything in that's sitting in the stomach, it can't move forward because the small intestine is paralyzed. And so they're going to have vomiting. They're going to continue producing bile, which is going to continue to build up. So they'll continue to have vomiting. So typically we're going to have an NG tube in that patient to decompress the stomach. They're going to be NPO temporarily. And then there are some medications that are given sometimes to improve peristalsis. The next complication we're going to talk about is a fecal impaction. And this is really a complication usually of constipation. It's when hard stool is collected in the rectum gets stretched, liquid or even solid stool can leak around that impaction. And because the rectum is stretched, the sphincter is not as effective. And so liquid stool the person may leak liquid stool. They may also pass ribbon-like stool if there's a big impaction and there's softer stool behind it that's trying to come through. It may squeeze through in a sometimes it's ribbon-like. The management. The first management is to get the impaction out. That patient may have stool softeners, but they're more likely going to need enemas or suppositories to get rid of the impaction. If that's not effective, then digital disimpaction can be used. And if they're going to have digital disimpaction, then an oil retention enema can soften that stool up and make it easier. To digitally disimpact a patient, you want to pad the bed really well. You're going to glove up, use plenty of lubricant, and gently use your finger to break up and remove that hardened stool. We need to be monitoring this patient for vagal nerve stimulation because they can develop bradycardia or rhythm changes. This is something that we should not delegate to unlicensed personnel because of the risk of bradycardia. Okay, in the next section, we're going to talk about diarrhea.